Yeah, good morning. Thank you for having me. So I was given a pretty tough topic, but we'll try to make it through this. So these are my disclosures. Another disclosure is, not many of y'all may know this, but since a child, I always had an Olympic dream. What does this have to do with anything? We'll get there. So this is me back in college. I wanted to go to the Olympics. However, I didn't get to make it there, but I think I turned out pretty well. But a new dream was born from the Olympics this year when I saw this man. I had a dream that I wanted to be able to include this in a talk, and I just want to give a shout out to my girl, Helen Burney, because she asked me to do this, and she let me realize my Olympic dream. So what does this guy have to do with anything what I'm going to be talking about today? Imagine the pain that he went through with this injury, not really injury, I guess, he just knocked off the pole, but imagine what he went through, not only from the penile pain, but also the emotional pain of not being able to realize his Olympic dreams. So that lines up with these patients that we have. With these patients, they have this pain that we can't figure out what's going on. The other thing is that this is not a huge population within our patients. However, these squeaky wheels do get that grease because they are very psychologically distressed. They have reduced quality of life, so they're going to be in your office complaining. The other thing is that there's a challenge with the diagnosis because there's multifactorial things that are playing into this. It often will overlap with other diseases like Peyronie's, chronic prostatitis, and pudendal neuralgia. So let me set the scene for you. You're at the end of your clinic, you're dancing, you're ready to go home, and then you pick up the last patient, is penile pain. You know, you have to kind of fix your face, put your poker face on, and being the boss, sex med doctor you are, you're going to go in that clinic room. However, when you get in there, you have a man that is weeping because he doesn't know what's wrong with him. So hopefully after this talk, you'll have a little bit better idea of what we can do to help these men. So what's the workup that you should be doing for these men? First, when you're looking at them, you want to get a really detailed history on them. You want to kind of figure out, like, when does this pain start? You want to get like what I call a pain mapping. So you want to figure out, where is the pain? Where is it coming from? Is it radiating anywhere else? Because that's going to be important because, like I said, it does overlap with other things. The other thing you want to do is a physical exam. However, with a lot of these patients, a lot of their physical examination is going to be completely normal. You also want to get labs. So I like to get hormone labs on these patients just to see what their testosterone and other hormone levels are. As far as diagnostic modalities, a penile ultrasound is useful in these patients. You can also consider a pelvic MRI to see if there's anything within the pelvis that could be causing these issues. But consider other imaging, just like you saw from San Diego Sexual Medicine. This is where I learned it from my fellowship father over there. You want to get other imaging. You want to look at their spine, their hips. There could be other reasons that could be radiating to this to the penis. And then if you have the ability, you can do nerve conduction studies. So as far as a differential diagnosis, we're not going to be like Elmo here. We're going to really put our thinking caps on. Like, could it be a urethritis? Could it be a prostatitis? Also, could it be some sort of structural causes? Now, that doesn't quite fit into what I'm talking about, but it could be Peyronie's disease, or they could have had a penile trauma. It could be neuropathic pain, so this could be from their pudendal nerve, and also pelvic floor dysfunction. This is very important, I think, in order to be able to treat these patients. And then you want to think about the psychogenic factors that could be causing this. Are they very stressed at home? Are they having stress in their life that's being manifested as penile pain? So I decided to kind of focus the talk because there's a whole bunch of different reasons you could have this penile pain, and hard flaccid syndrome is something that everybody's afraid of. So this is just a review article. They went through 7 different articles and they looked at different symptoms, treatment options, and how they went through and managed these patients. So what they said was, for presentation, you typically will have semi-rigid penis at the flaccid state. They'll have numbness and coldness within the glands, typically with a little bit of decreased sensitivity. They'll have new onset ED. So this could be a whole host of things. It could just be decrease in their morning and night erections. It could be that they need more excessive stimulation to be able to get an erection, and then they have difficulty maintaining it once they do get it. It could be decrease in their rigidity, and again, they have that soft, cold glands. And then the other thing that they may have is the penile and perineal pain with urination and ejaculation. But the most important thing is that these patients are going to have this emotional distress with this. And they have anxiety, depression, and then that leads to decreased libido and can lead to insomnia. With these patients, they can be anywhere from our late teens up to the 70s, but most of these patients are going to be our high-strung 20s to 30-year-olds that are going to be seen in our office. So they came up with this schematic, and I really like this because I'm a huge proponent of educating our patients so they understand their disease process. So the way that you enter this, I would call Ferris wheel of hell, basically, is that you have some sort of trauma to the penis at the base. And I know it's kind of small, so I enlarged it. And then you just go through this vicious cycle where you start having neurovascular problems and you start having vascular issues, and then you get the emotional distress from the pain, and then that becomes sympathetic stimulation, and then your pelvic floor becomes spasmed, and then it just continues to go on and on and on. And then from that, the outcome is that you have venous outflow obstruction, along going at the same time, you're having the myoneuropathy, you have the semi-hardness state, and then you're going to have the erectile and ejaculatory dysfunction. And then you get the physical disturbances and then the ultra libido. And again, this is just a vicious cycle that keeps going on and on with these patients. So how can we get them off of this Ferris wheel? Well, I tell them that this is going to be I'm throwing everything at you, including the kitchen sink. Just go with me. It's going to be a journey. So what are some of the things that I have in my mixed bag of tricks? So I like to make sure I'm talking to them about behavioral modifications. Are they getting good sleep? Are they eating well? All these things do play into it, especially like we've seen from Dr. Perlman and her sister. Like all these things are very important to how our patients are doing. The other things you could do are different medications like gabapentin, NSAIDs, or topical lidocaine. Other medications, PD5 inhibitors have been discussed, antidepressants. The main thing that I really like to focus on is physical therapy, because that pelvic floor physical relaxation is definitely going to help these patients. And then you cannot forget about that psychotherapy, because that is going to be a huge part. You have to get them out of their head. You got to break that mindset so they can get better. And then as far as interventional approaches, there's a couple of different things that have been discussed. You can do like a dorsal or pudendal nerve block for these patients. There have been discussions of doing penile nerve decompression. However, those haven't had like the best outcomes. There have been some recent studies with low intensity shockwave therapy, but as we know, those studies, we need a little bit more with that. And then even neuromodulation. So I will discuss neuromodulation a little bit later, because I am starting to look into that a little bit more with our patients. So this came from Yafi and his group. They took a survey at the 2023 AUA, and they went to sexual med practitioners, and they asked them a bunch of different questions to see how much they actually knew about HFS. So there was 37 attendees. They did 36. We got 36 responses. Then there was 35 urologists and 1 mental health provider. Out of that, 23 of the respondents said they actually have seen it, so that they were able to continue on. So from that, what do we learn? Our knowledge. So our knowledge, 35% of our colleagues have known about this. 35% of them learned about this from their other colleagues. 26% learned from medical journals, 17% had learned from conferences, another 17% learned from our patients. And that's important, because our patients are bringing this information to us, because they're going on these on the websites, like talking to other patients about their issues. And then there was also one that had reported that they first learned about this from an online pelvic floor physical therapist. So I implore you to find somebody in your area that can help you with this. Now, as far as diagnostic approaches, most of them said that they just utilize clinical history. 16 said they also relied on self-diagnosis, and then some imaging was used, but it didn't really specify which imaging they had, modality they used. So as far as prevalence goes, 74% said they've only seen 1 to 10%. So again, this is not a very highly prevalent disease process, but when these patients come into your clinic, you will know about it. And then as far as etiology, 18 out of the 23 said there was some sort of urologic trauma with this. Most of them said that they had normal exams, and then penile Doppler ultrasound was used and with 8 of these practitioners, and they said 7 of them had some sort of abnormal findings. So as far as treatments go, again, it's the same treatments that I discussed earlier, but the main thing is only 13% felt like they were successful. So that's why it's very important that we are listening to our patients and working with them together, so that way we won't have, like the bad feelings ourselves about it. And another telling thing I thought was important is, did they believe it was real or not real? okay? So there was 4 of them that actually said, no, it is not real. The main thing we gotta remember is that these patients do have an issue and we do need to be listening to them. So quickly, I'll go through this. This is axon therapy. This is a new modality. It's a magnetic pulse system. We just got it at our VA, so this is Dr. Marshall Better, and he explains it as is when you have chronic pain, it changes the synaptic makeup, and then the axon magnetic waveform is able to reverse the negative synaptic connections. So this may be a way for us to break them out of that cycle and allow them to get better without doing really major invasive procedures on them. So the major takeaways from this is that, this is a very difficult disease to be able to diagnose and treat. Our patients just want to be heard. They want us to listen to them and hear their problems and try to help them the best way that we can. And you will need multiple therapies to be successful. Thank you.